Hello, my name is Saber Khan. I'm a first-year internal medicine resident at Creighton University. Today I'll be presenting on fever in a returning traveler, a case of dengue fever. I would like to thank Dr. Manasa Valagapudi for being a mentor and helping me on this case. Our case is a 27-year-old woman contacting her primary care physician due to the following symptoms: fever, chills, nausea, diarrhea, bone pain, and a sunburn rash over her bilateral upper extremities. She has recently returned from her trip from Thailand 24 hours ago. Initial physical exam indicated that she was febrile at 100.6. Additionally, integumentary exam showed a maculopapular rash over her bilateral upper extremities. Musculoskeletal exam did show also bilateral upper and lower extremity joint pains, but she had normal gait and no other neurological deficits at that point in time. Initial laboratory findings ordered by the primary care physician indicated leukopenia at 1.9 thousand, thrombocytopenia at 83,000, AST at 109, ALT at 71, and dengue, IgG, and IgM within normal limits. The patient was prescribed ciprofloxacin and diphenoxylate atropine for empiric treatment of gastroenteritis initially. The rash, though, worsened with ciprofloxacin, and due to concern of drug reactions was discontinued, and oral diphenhydramine was started for symptomatic relief. The patient then followed up with a primary care clinic 7 days after symptoms started, showing progression of the blanching rash, now from her head to her bilateral lower extremities. She continued to also be febrile, and as such was directed to a local hospital for further testing and care. During the hospitalization, repeat dengue IgM and IgG were obtained. The IgM was elevated at 38.12, and the IgG this time was elevated at 3.32. With the patient's signs and symptoms, as well as now elevated IgM and IgG for dengue fever was diagnosed. Treatment was IV hydration and antipyretics at this point, as the patient was hemodynamically stable. Additionally, daily CBCs, LFTs, and CMPs were conducted. The patient was observed in the hospital for 4 days. Laboratory testing indicated that her transaminases elevated during this time, but plateaued and stabilized with an AST of 93 and an ALT of 88 at day of discharge. Her hemoglobin was stable during this time at 12.1, never requiring a transfusion. She was thrombocytopenic. When she arrived, it was 36,000. On day of discharge, it had elevated to 61,000. The patient had a 4-week infectious disease clinic follow-up. At this point in time, the patient had completely resolved her fever, her rash, her leukopenia, thrombocytopenia, and transaminitis. Now for the discussion. Dengue is a leading cause of acute febrile illness among travelers returning from Latin America, the Caribbean, and Southeast Asia. Our patient was returning from Thailand. Even in patients with compatible clinical presentations, serology can be falsely negative, especially during initial stages of the illness, and this can lead to misdiagnosis of the disease. IgM against dengue virus can be detected with an ELISA after 4 days of fever onset. Prior to this, IgM testing can be negative. Patients presenting in the first week after fever onset should receive an RT-PCR or NS1 testing in addition to IgM for dengue fever. In patients presenting greater than 1 week after fever onset, IgM testing alone is most useful. It is imperative, though, that a thorough history be conducted in the presence of high clinical suspicion for dengue fever. Negative initial testing should not dissuade the possibility of a diagnosis. This is secondary to a dengue fever converting into its hemorrhagic form, requiring additional supportive care. The following are my citations.